there's any questions I could answer, I'll be more than glad to. Otherwise, I know it's late and some of you want to go home. Is anybody has any questions at all?
Do you just do one leg at a time?
I do. Yeah, that's a very good question. The insurance companies are gradually changing the bylaws. I noticed in February they came, they basically want you to do all the 4 veins if you can. I know nobody else in the United States is doing it. So when I went to New York about a month ago, that's the first thing I asked. I asked everybody, are you doing it? The only guy who's doing it is in Midwest, is in Arizona. And he told me, he said he doesn't accept, he only accepts cash. So, of course, when you pay to have all your veins taken care of, then he gets an anesthetist, and he takes care of all the veins at the same time. And I told him, when you do one vein, first of all, you can only put so much numbing medicine. What we use is tomacin anesthesia, which is used for liposuction. You can only put so much. It's toxic after, you can't give 2 liters of, one of the things the insurance companies were telling me, well, you can put up to 3,700 cc's of fluid of tomacin anesthesia. You know how much fluid that is? And what they're confused is, actually, I've got another patient who's come, I haven't treated him yet. He's an anesthetist. He said, Dr. Darzik, he said, I did a lot of liposuctions. He said, they pour it in and suck it out. You leave it in. The body, so it is toxic. And thank God I've had 0 complications. I never had anybody with arrhythmia or angina. I mean, you're taking care of patients' veins. You don't want them to have a clot or get arrhythmia or die from a procedure. The insurance companies, all they seem to care about is money, how much they can save. Because if you do the second procedure, they pay you half the amount, and that's all they think about. And I've even called Blue Cross and said, listen, I'll give you a break. Just let me do it the way it's supposed to be done. So the answer to your question is, the second thing is, when you go to do the other leg, when the patient is laying down, the vein is collapsed. Any of you have a sudden IV, it's like when you're laying down, the vein collapses. And you've got to be able to get into the vein. Now, if you can't get into the vein, you find another one somewhere else. I have to get into that vein. That's the only vein that we are after. So if you can't get into it, you've got to send them home. We've done that a few times, or send them out, they stand around for a while, So when you're lying on your back, so I told him, I said, so what do you do when the vein collapses? He said, we've got a heating pad. We put patients on, they lay down on the heating pad. And I swear to God, later on in the 3rd day, when he was giving a lecture, he was talking about complications of venous disease, and one of them was an ulcer on the back from the heating pad. so he never told me that. I said, what happened there? He said, the temperature was set too high, and the patient was anesthetized. They give him large dose of Valium, and so the patient is asleep and gets up with burn on his bottom. So first rule of surgery, do no harm. Everything else can follow. But that's the reason we do one at a time. And honestly, especially the first procedure, patients are so happy to get up and walk out of there, and the first thing is, was that it? That was it. The second time, they're more comfortable. But it doesn't matter how brave they sound. I know if I was on that table, it doesn't matter how much I trust my doctor is telling me everything. Until I get up and I'm out of there, you don't believe it was that simple. So I think doing 2 procedures, 3 procedures, I think is too much. Now I do 2 veins on the same leg on the front at the same time, because it's already numb. You can put a little bit more, but I don't do the front and then turn them over and do the back, or one leg and the other.
How long in between do you have to wait to get done?
That's a very good question. Really, we are talking about a toxic amount of medicine. So I know that medicine comes out of your system within like an hour. So why couldn't you do them the next day? I've had patients that for whatever reason, they had to have it done in a hurry, and we've done them every other day. Saturday, we were at the office. We had a patient who already had a bandage on one leg. He came the next day to have the other. So you can really do it the next day if you want to. I like to do it twice a week, I think, because people, after you laser them, you want their stockings on, and patients don't like to wear their stocking for very long. So especially around here, summer gets hot, so you want to come out of the stocking as soon as they can. So people want to do it as quickly as they can, so I do them, about twice a week, or even every other day if you have to. I'm sorry?
I just had a question about, what you do for pain management during the procedure. Do you sedate them? Do you just do topical? What, anything?
That's a very good question. I only give them 0.5 of Xanax. That's it. And we give them some Ultram. I give them because Ultram doesn't make you drowsy. I fractured my wrist a few years ago skiing, and I had hardware in my hand, and I didn't want to take any narcotics. My wife is a nurse, and she got freaked out as soon as I asked for a second Percocet. Bottom line is, I took Ultram the day they took the pins out, and I did fine with it. So it doesn't make you drowsy. It's not addictive per se. So we give them an Ultram, and we give them Xanax 0.5. Now, one thing I didn't mention, there is this technique that I'm using, which basically makes the whole procedure pain-free. I use the same cannula they use for Tomacin, giving Tomacin for liposuction. And I think doing laparoscopy and all that helps out to be able to do it, because I don't have the image here, but I put the probe, the catheter next to the vein, and under ultrasound, basically we are injecting the numbing medicine and the high pressure into the leg. We blow the bag, a pressure bag. So when you turn the medicine on, the track is numb when you get it, because I already numbed it. So then I put the catheter right where the IV came out. So we put the IV in, put the laser in, take the IV out. I've still got a little opening. I put my trocar, my Tomacin cannula in there, and I pour in the numbing medicine. A jet of numbing medicine goes around the vein. There's a line of least resistance. It stays around the vein. Now this area is numb. I put the catheter into that numb area, inject some more. So we kind of walk up the leg. All they feel is pressure. They say there's a little pressure there, but they tell me it's not painful. What they have told me on the scale of 1 to 10, a dentist being a 10, they say it's a 2. Some of the patients are here, and they can tell you it is. They tell me, I've never had it. They tell me this is painless. Really.
I wouldn't even say it was a 2. I think just that initial sting of
the numbing,
good and then it was not.
That's what I normally hear. Now for our men patients, that doesn't apply anymore because this is the honest truth. I was last week. I was there doing a very procedure. My wife came in to tell me, I had to pick up the kids or something. I forgot it. And I'm talking with him. He's screaming in pain. And I looked back and said, what's the problem? He said, it hurts. I said, I'm not touching you. I'm talking to my wife. I swear to God, some of you guys were in the room, true or false. I don't know. I'm a man myself. There's something wrong with us. I don't know what it is. But it doesn't hurt. I mean, 99% of the patients tell me it's pain-free. And after surgery, honestly, it's zero pain. That's just unbelievable.
What's the downtime?
There isn't.
You're done on Friday, can you go back to
Absolutely.
work Monday, as long as you have your stockings on?
Absolutely. Our Mondays, our Fridays are busiest for that reason. We sometimes do 15 lasers, because everybody wants to have it done on Friday, so you can go to work. They tell you this can be done during your lunchtime. No, not really. First of all, how many people can take Xanax and go to work? Okay, number one. So I know they say it on television, a lot of doctors are saying it. That's not true. The second thing is, all this Tomacin I put in the leg is going to come out. So we put this bulkhead dressing so that you don't get your wet pants and you don't get wet stockings. So we leave that in. The next morning when you take that dressing off, was it soaked the next morning, or is it kind of wettish? Not too bad.
Just maybe a little drainage.
There's drainage in there.
Not really soaked.
But
But the
that's
next day I was fine. My leg was still just like a little, I still had some numb
feeling in there.
Other than that, I was able to get up and go to everything.
Function. That's the bottom line. And they put their stockings on and they're ready to go. We want them to walk 30 minutes that day. The next day we want them to walk at least an hour. So walking is a good thing. You want them to walk. You don't want them to keep it still. So.
Is there a limit to sun exposure?
No, because the laser is on the inside. There's no, you don't have to avoid the sun or worry about the sun. Now, there's a dot, and that dot potentially can get darker, but if you really were worried about it, you could put a little, sun lotion right in that dot. But honestly, no. I mean, that's the nice thing about it. It's not topical laser. And a lot of people are using topical laser just for those spiders. That is not permanent, at least the best of my knowledge. I've never found a single documentation that it is a permanent treatment. Still, sodium tetracycline sclerotherapy seems to be the only one which seems to work. I use vein wave, which is a microwave technology for really, really tiny veins, because you can go out in the sun. I don't know how you can have anything done in Wilmington, North Carolina, if you are supposed to avoid the sun. Honestly, because we've got the sun here for almost 7 months, 8 months, and how can you avoid it? You can't. But no, I don't do any procedures which basically requires avoiding the sun.
Are spider veins related to venous insufficiency? Does it cause them?
Again, that's a very good question. After 13 years of doing this, I've been doing it a lot longer, but when laser got approved by the FDA in the year 2000, I've been, so I think as far as, I'm sorry, I got distracted there, the spider veins. Lesson I learned, don't ever think that the spiders are skin deep. What are free vein consults we do, I always have an ultrasound there. I just look and see if there's anything else going on. It might be just that, and that's great, but there's several issues with that. Number one, you find out the patient has venous insufficiency. I said, doc, my leg doesn't hurt, I'm fine. I just want these spiders gone. At least you can be honest with your patient and tell them, you know what, I'm injecting this, but it can come back, and it can come back with vengeance. Because I compare it to a rose bush. When you clip one, you get 3 in its place because you didn't take care of the root of it. The other thing is the risk of clot formation. When you inject a spider, that medicine travels to larger veins, and then from larger veins to even larger veins, and eventually you're in your long saphenous vein, and that is going to drain into your deep vein, and then now you've got pulmonary embolus or something like that. So you really need to know what you're injecting. You notice the one that with Trivex I was showing, that vein on the front went way back to the back. So in order to get rid of that, you really should have gone in the back and closed that. So the spiders makes you at least could suggest that they could have venous insufficiency, so always do an ultrasound. There are some spiders on the lateral aspect of the leg. They look like a sunrise or sunset. They are never related to the deep system. In fact, I looked them up recently. They're caused during, when you're in the womb, they are supposed to disappear, and they don't. And when they stay there over time, I'm sure you've seen it. It's like the sun coming out. It's a perfect circle on the lateral aspect of the thigh. They are not related to venous insufficiency, and those, we usually inject them, and they do quite well. If the patient has venous insufficiency and they have spiders, I like to inject all of those myself as opposed to my mid-levels, because I make sure I'm way away from the deep system, and I make sure that when I'm injecting, I don't inject so much that they eventually get washed into the deep system. Again, I don't mean to scare anybody here, but there was a case in England where a young girl had her vein injected and went home and threw an embolus and died. And there was a huge lawsuit because their argument was the injection, caused it. And there's a lot kind of clotting, issues that people have. I'm sure she probably had was factor V, factor V homozygous issues. But no, you don't take these things too lightly. And every paper I'm reading now from Europe, from here, they're all saying do an ultrasound. So they're all coming to the same conclusion that I did on my own, is, don't ever think these things are skin deep. Now, you want to do some sclerosis, there's nothing wrong with it. But if it comes back, or if the things are not working out the way you should, get a vascular surgery consult, trust me. Let them do an ultrasound and check it out before you go further. Great. Is there any other questions? Well, again, thank you very much for joining us, and thank you, Ms. Sandra, and all the hard work, and John particularly. You can rest now.